My name is Ted Corrigan in the VCU EMTP program, and today we'll be talking about mesenteric ischemia. Mesenteric ischemia is inadequate perfusion to the mesenteric vessels caused by a thrombus, embolus, or ischemia, compromising the function of the intestines. It's also known as the MI of the stomach. Eventually will lead to dead bowel and necrosis. So a few causes of mesenteric ischemia are things such as AFib, vascular disease, and smoking. All these can affect your arteries and veins and eventually can lead to these blocks, emboluses, thrombolysis, etc. down toward your arteries and veins to your stomach in the mesentery. Here we have a picture example of mesenteric ischemia. You'll see right here multiple mesenteric vessels that are going into the small intestine. Now, as a clot forms in one of those vessels, then the perfusion will cease, and eventually we will have necrosis and dead bowel stuck in the small intestine. Some of the symptoms of mesenteric ischemia are severe abdominal pain, vomiting, nausea, bloating, melena, and weight loss. A lot of times patients will start experiencing some of these pains and symptoms after they've eaten a meal. This is generally the first time that they're going to start feeling these symptoms, and which will lead them to the severe pain and calling 911. If your patient is experiencing mesenteric ischemia, we need to transport them as rapidly as possible. Remember, in this case, time is bowel. Dead bowel eventually leads to necrosis. In addition, we need to monitor their vitals closely and check for sepsis as well as signs of shock. We need to monitor these vitals every 5 minutes to reassess and see if anything has changed. We additionally need to resuscitate their fluids should they be dehydrated, as well as possibly hypotensive. If they are severely hypotensive, you may even look into using some sort of vasopressor to stabilize. Once you've transferred your patient over to hospital care, they're going to want to look into getting an x-ray done, possibly a CT with some contrast, or even angiography, where they can look in the actual blood vessel for blockage. As soon as it is confirmed, then they're going to work on at least getting blood thinners and seeing how that goes. If not, they may have to do an angioplasty where they're going to be stenting or ballooning that specific vessel to try and open it up and get that block moving through. They may look into thrombolysis or fibrinolytic therapy. Just depends on how quickly you've gotten the patient there and how long this has been going on. Or they can also look into an embolectomy, which will be actual surgical removal of the block. Below are some of my references, and thank you for taking the time to listen.